little struggle there. Sorry about that. So before we get started, a little housekeeping to go over. You're all on mute, so please send any questions through the Q&A function in your Zoom panel. This is located at the bottom of your screen. I'll be addressing any questions that you have with Judy at the end of the session. I'll also be sending out the webinar recording and your CPE certificate for credit from the Academy. My name is Kate Scarlatta, for those of you that do not know me, and along with the rest of the clinical team at Epicure, I welcome you for a lovely evening of education. I have the privilege to support Epicure's Partners in Health, which involve many of you clinicians, and we really appreciate you working with us and the support that you give us and our customers and many patients that live with digestive conditions. So Epicure really has partnered with dietitians from the very beginning, which of course is near and dear to my heart. Laura Manning at Mount Sinai was really heavily involved from the beginning, helping Epicure with a number of different ventures, education, and being a resource for Epicure, and continues to be a partner in health with Epicure, as are many dietitians. There's many partners and thought leaders that we work with, and we really appreciate this sort of collaboratory environment that we've found ourselves in as a food as medicine company that is aligned really nicely with many people in the GI field. For those of you who are well aware, we have a Partners in Health program, and this provides a number of resources for our clinician base, including discounts off our food, these fabulous webinars that are provided by top-tier key thought leaders in the GI space, as well as educational materials. And we're here for you and really welcome your input on other ways that we can partner with you and provide resources to guide and help your practices as well as your patients. So Epicure is really a healthcare company that creates food as medicine, but it's paired also with Michelin star chefs. So the food is really delicious, whole foods, freshly made and delivered to the doorsteps of our customers, and it has been very well received. We first started with a digestive health menu focusing on low FODMAP and gluten-free foods for a number of digestive health conditions, and kind of consider our offerings Mediterranean diet with a twist. We know that the low FODMAP diet is complicated and nuanced, but we also know that it works for a great number of people that are suffering with irritable bowel syndrome. In fact, research has shown that up to 86% of people will receive symptom reduction with the low FODMAP diet. So to order Epicure, it's really quite simple. Our customers just simply pick menus, they schedule their delivery, receive a box, and eat delicious foods, and then prepare for the next week. This was a testimonial that we received during this pandemic that was really quite lovely to receive. And just quickly, I'll read it because it really touched me. I just got back home at almost 10:30 from my pediatric practice after seeing my last visits in isolation. Thank you so much for your dedicated service, because certainly I can't afford an IBS flare-up right now. Bless you, gang. And we get many of these testimonials from patients, which really drives the work that we do here at Epicure to support you while you support patients that are challenged with digestive conditions. So without further ado, I'd like to introduce Dr. Judy Nee. As I mentioned, she's in Boston along with me as an assistant professor at the Harvard Medical School. She currently focuses on functional gastrointestinal and motility disorders at the Beth Israel Deaconess Medical Center. As an expert in this area, she engages in research, particularly for complex functional gut disorders, including refractory constipation, gastroparesis, pelvic floor dysfunction, and irritable bowel syndrome. Dr. Nee will be discussing the controversial role of small intestinal bacterial overgrowth in irritable bowel syndrome. In addition, she will discuss the pearls and pitfalls about the diagnosis of Sibo, as well as evidence in regards to its treatment. So thank you so much, Dr. Nee, for being here, and we'll let you pull your deck up.
Great.
If you could share.
I'm going to share. I'm just sharing now.
Terrific.
Great. Everybody can see?
Yes.
Okay, excellent. So thank you so much, Kate. You know, I was just thinking about even going back to when I was training as a GI fellow, that one of the areas that I gravitated towards was this small intestinal bacterial overgrowth, and we were allowed to choose kind of any topic for our grand rounds. And this was actually the topic that I talked about. The interface and the overlap between small intestinal bacterial overgrowth, or SIBO, with IBS is really complex though. I have patients who I see now at the IBS and Motility Center at BI, many of whom have chronic symptoms, right, of diarrhea, constipation, abdominal pain, bloating, for which I would have called IBS, but they're actually coming in with this diagnosis, not uttering the words IBS, but saying they have SIBO or refractory SIBO or recurrent SIBO. And what I want to do with this talk is, in honor of IBS, in honor of this entity that has so much in it, I want to talk about the basics of bacterial overgrowth, but really kind of parse out, now that there are two big publications now, one consensus from the North American Consensus on breath testing, as well as the ACG guidelines, our big society about bacterial overgrowth in particular. I want to use that to discuss this interface, this interaction between bacterial overgrowth and IBS. So moving on, I have no relevant disclosures. If you actually Google SIBO, this is what you would find. And this is just one of many websites that you can find, but 10 signs you have SIBO. Number 1, gas, bloating, diarrhea. Number 2, abdominal pain or cramping. 3, constipation. 4, a diagnosis of IBS, or even if you have IBD. If you go down the list, if you have any chronic illnesses, including fibromyalgia, chronic fatigue, diabetes, other autoimmune diseases, you basically could have small intestinal bacterial overgrowth. And on the bottom part of this, it actually says, because of the many ways its symptoms manifest in different people, sometimes you have no physical signs, you may have no physical symptoms, and you may still have bacterial overgrowth. And in fact, an estimated up to 15% of people healthy will actually have SIBO. So if you are a patient who has symptoms, I could see very much how Googling these kind of things makes you kind of crazy about SIBO, that yes, maybe this is what I have and that it's gone untreated. So what I'm going to do in this talk are 3 kind of basic areas. The first is I'm just going to define small intestinal bacterial overgrowth, its associated symptoms and conditions, identify the criteria and talk about that diagnosis, move on to this controversial area of breath testing and SIBO breath testing, including the how-tos, and really discuss the pros and cons of why you would get SIBO breath testing. And then finally, I'm going to talk about SIBO treatment and recurrence, so particularly antibiotics, and then in the last part, actually bring up what a lot of us are interested in, which is diet and bacterial overgrowth. The concept of small intestinal bacterial overgrowth is simple, right? It's the idea that there, or condition in which bacteria are present in increased numbers, resulting in excessive fermentation, inflammation, or malabsorption. And our gut is full of bacteria. It's so attractive to think about this concept. Our stomach starts with less than 10 to the 3rd bacteria per mL, and it's relatively sterile compared to when you go into that small intestine. The normal amount of bacteria is usually 10 to the 3rd to even 10 to the 4th bacteria per mL, and then you go into this very diverse microbiome-rich area into the colon where there's 10 to the 12th bacteria of both anaerobes and aerobes. The common complaints that people all over kind of complain of, bloating, abdominal pain, altered bowels, are common complaints for those in bacterial overgrowth, but also in IBS. The pathophysiology has been discussed, it's been described in many different sources, but you can develop bloating and flatulence from degradation of carbohydrates leading to short chain fatty acids and production of gases like hydrogen, methane, carbon dioxide. You can get diarrhea from carbohydrate malabsorption, fat malabsorption, hydroxylated fatty acids, and free bile acids. You can get constipation. And this is, I'm going to talk about this later, but because of methane production, this can slow colonic transit. In particular, it can delay ileal transit velocity. You can get nausea, anorexia, bloating because of changes to motility from bacterial end products, such as intestinal neuroendocrine factors. And an example would be something like nitric oxide. You can get abdominal pain. Bacterial end products like substance P can lead to discomfort, pain that people complain of. And lastly, in more severe cases, you can get anemia and weight loss from B12 deficiency and fat malabsorption, even steatorrhea. This is from the newly released ACG clinical guidelines on Sibo, which was just released in November of 2019. The issue has been, what kind of symptoms would one present with that you should say, yes, you should get testing for Sibo, or I'm suspecting Sibo. And according to this ACG guideline, there's no single symptom specifically attributed to Sibo. Symptoms often masquerade as other diagnoses such as IBS, functional diarrhea, functional dyspepsia, or bloating. And later on in the document, it actually says the most prominent symptom of Sibo is bloating. So there are a lot of different symptoms that can be associated with bacterial overgrowth. What are the causes? I generally put this into kind of three main categories, which is mechanical, motility, or systemic related. Mechanical would be structural changes of the GI tract. And Sibo was initially described in patients who had Billroth-2 and Roux-en-Y gastric bypass. It can occur, though, from adhesions from previous surgery, inflammatory bowel disease, small intestinal diverticulosis. You can have intestinal blind loops from these kind of surgeries, reverse segments. And then again, as gastric bypass gets more and more popular or more common, these patients are at risk also of bacterial overgrowth. Medications. This can change the flora because of PPI use, meaning there can be hypochlorhydria, and that can be as a result of PPI use or chronic atrophic gastritis. Opioids are very common, commonly can slow down the GI tract. Motility is another huge factor for causes of bacterial overgrowth. And we usually talk about disordered peristalsis of the stomach or small intestine when we talk about this overlap of Sibo with IBS. So it's thought that there's lack of this interdigestive phase 3 activity in IBS, but it's not actually known. And I'll talk about that in a little bit as well. But if you get intestinal pseudoobstruction, diabetes, that can also alter the motility or the movement of the GI tract. In addition, you can have immune-related issues, so mucosal defenses in the small intestine because of IgA deficiency, HIV, combined variable immunodeficiencies, that can also lead to bacterial overgrowth. I think I'm on a set timer. We'll see. Okay. Sorry. And then lastly, metabolic and systemic diseases can put you at more of a risk of getting bacterial overgrowth. And that includes cirrhosis, pancreatic insufficiency, scleroderma. All of these conditions can be associated with increased prevalence. But why in particular is it that we see bacterial overgrowth more commonly in IBS patients? This is a retrospective cohort and just one example of many studies that have tried to figure out what are the risk factors associated with and not associated with bacterial overgrowth. So a retrospective cohort looking at patients who had these common symptoms, abdominal pain, bloating, diarrhea, constipation, weight loss, and they underwent either lactulose hydrogen breath testing or glucose breath testing. In the end, out of about 2,000 patients, there was 175 patients who actually had positive bacterial overgrowth, and they defined this by a 20 part per million rise within the 2 hours that they followed them. And again, not to look at the particulars of whether you're associated with it or not, because you can find another study that shows that a factor that's associated here may be not associated on another study. But in this particular study, they found that your risk increased with use of PPI, with gastrectomy or gastric surgery, impaired motility or delayed gastric emptying, neuropathy, hypothyroidism, and then diabetes. But surprisingly, the risk factors, again, in this particular study, they didn't see Billroth-2s being, resections actually being an issue or risk factor. There was no increased risk with loss of the IC valve. Appendectomy, colonic resections did not actually change your prevalence of bacterial overgrowth, and even immunoglobulin deficiencies or steroid use did not increase your risk. What about PPIs? It's really common in our IBS population to give PPIs for all sorts of symptoms, including reflux. Perhaps it's that we give IBS patients too many PPIs. In this particular study in 2016, they actually used duodenal aspirates in IBS patients, and they looked only at aerobic species in about 900 consecutive patients. And they looked at those who were on PPIs versus not on PPIs. Sibo was defined as a growth of greater than 10 to the third CFUs per ml. And what they found in this study was that no, actually PPI did not change the prevalence of bacterial overgrowth in IBS patients. So you can see here those who were on, not on PPIs and those who were on PPIs, that bacterial growth was similar. And then they parsed out in looking at IBS diarrhea versus non-IBS diarrhea. And again, there was no difference between those who are on PPI for long-term or off PPI. What about motility? Maybe it's the issue of in IBS, there are those who have fast motility or rapid motility and those who have slow motility. In this study in gut in 2007, they took these patients with IBS and they underwent small bowel manometry and culture of the jejunum, so they aspirated from the jejunum. And for controls, they compared this to 26 healthy subjects. They had a couple of definitions of bacterial overgrowth, and one of them was that if it was a greater than or equal to 10 to the 5th colonic bacteria per ml. And then they also looked at mildly increased counts of small intestinal bacteria, so greater than or equal to 95th percentile from the controls. And what they found here is in these jejunal aspirates, it was a very low prevalence of bacterial overgrowth, which is not uncommon in studies when you look at aspirates in IBS. So only 4% were diagnosed with bacterial overgrowth based on that, that higher threshold, that high threshold 10 to the 5th bacteria. Cultures, though, when they looked at that lower cutoff, were more frequently seen in those with IBS. So it was more common at about 40% versus the healthy controls that are about 10%. And then when they looked at the motility pattern, they said it was non-specific in terms of that motor pattern. So they tended to have, these bacterial overgrowth patients tended to have fewer activity fronts. Signs of enteric dysmotility were more common, but there wasn't really one overarching motility pattern that could inform whether or not somebody had bacterial overgrowth. And this just points to the fact that, it is so fascinating, that the bacteria changed the motility and the motility changed the bacteria. How do you diagnose bacterial overgrowth? We always go back to this idea of the gold standard, which is jejunal aspirate. And the classic definition of bacterial overgrowth is greater than 10 to the 5th organisms per ml. So again, the normal concentration is usually less than 10 to the fourth organisms per ml. The consensus now is that it should be greater than 10 to the third CFUs per ml, and that's from the North American consensus and as well as the ACG guidelines that were just released. But jejunal aspirate is incredibly difficult to do. Studies do it because we want to be very specific about the diagnosis, but you need an endoscopy. You often contaminate that aspirate, and it's difficult for the patient to do this kind of procedure just to aspirate and then potentially not get the correct diagnosis anyway. It's all really fallen by the wayside because of this breath test. Breath test is easy to do. You typically use glucose or lactulose. And I'm just showing you here kind of the way that breath testing happens. And so what happens is that you ingest sugar. The sugar can be glucose, lactose, lactulose. Some people use sucrose as well. And you ingest the sugar. And then it gets into the small intestine where presumably there are some bacteria, and it creates these byproducts of hydrogen and methane in about 20% of the population. These gases are then absorbed in the bloodstream and then carried to the lungs. And then the concentration then is breathed out when the patient inhales or exhales into a bag, and we collect it every 15 minutes for about 90 minutes. In the usual way is that if there's a 20 part per million rise in that small intestine, we diagnose somebody with bacterial overgrowth. You have to prepare for this study. And so this is the kind of area that is not as well known, but at least there now are guidelines and recommendations about what to do to prepare for the test. The antibiotics should be avoided 4 weeks before the test. You should stop a probiotic. And I wrote here that this isn't clear, and there's not really a consensus, even though these guidelines say stop it. Nobody's really tested this area in a good way. If tolerated by the patient, they should actually stop their pro-motility drugs and laxatives at least a week prior to breath testing. So that includes Miralax, fibers. It includes all of the Linzess or linaclotide, lubiprostone, and it's sometimes hard for patients to do that. And so I generally say, if you have to stay on it and you cannot stop it, I just need to know so that I can interpret it appropriately. You should avoid complex carbohydrates the day prior to breath testing. You need to fast, so 8 to 12 hours of fasting before the test, avoiding smoking. No physical activity during the actual breath test. And according to the guidelines, it's not really necessary to stop PPIs. One of the reasons I'm giving you guys a lot of detail about this is I think that there are a lot of reasons for false positives and false negatives, and a lot of gray area. And so patients will know some of these particulars, and we just need to be really informed about that when we talk to patients about this, so that they're not deceived about what the results mean. You can choose between glucose and lactulose breath testing. And I have patients now who come who are very adamant about choosing one or the other. They're very informed. The reason, and I've juxtaposed these two, glucose and lactulose, just so you know, in our institution at BI, we generally choose glucose. Glucose is used in 75 grams in 250 cc's of liquid. You follow them for 120 minutes. The comparative studies, though, looking at 50 grams, 75 versus 100 grams hasn't been performed. It's just the ease of having 75 grams for glucose tolerance testing. The sensitivity for glucose breath testing ranges widely, right? So this sensitivity you can see is 20 to 93% and a specificity of 30 to 86%. Glucose is absorbed in the proximal gut. So overall, this underestimates bacterial overgrowth. It potentially will not get to the end of the small intestine. The positive predictive value is 80%, and that negative predictive value is at about 61%. Lactulose, on the other hand, is 10 grams in 200 cc's. You can follow it anywhere from 120 minutes to 240 minutes. The sensitivity is comparable to glucose, as is the specificity. Lactulose is not absorbed. So the interesting part about this is that lactulose used to be a surrogate for oral cecal transit time. And so it will hit the distal small intestine, but at some point it will hit the colon. And so if that transit through the small intestine is fast, potentially you could get a false positive when it hits that colon. The positive predictive value of this is 61% and negative predictive value of about 54%. These are the three different criteria that have been in the literature for the last 20 some years since bacterial overgrowth has been discussed. And I give this to you because it matters what the diagnosis, how they diagnose bacterial overgrowth. So in the literature, you can see a greater than 20 part per million rise by 180 minutes. You can see a rise of hydrogen before 90 minutes, meaning there was no set number, but they just said, hey, it could be 5, it could be 10, but it had to rise before 90 minutes. And then that third criteria that people can see in the literature is that there's a double peak. So an initial rise in the small intestine, and then a second peak that you know you've hit the colon. When you look at the studies and the detail of that criteria, so whether you're using the double peak, the hydrogen rise of greater than 20 part per million, or by 90 minutes or by 180 minutes, it's interesting to look at what studies will say are potentially increased prevalence in IBS. But when you look at these details, it's actually not that different between IBS and controls. One particular study that I'm going to call out is this Pimentel study in 2000. And Pimentel study is that landmark study that really linked IBS with bacterial overgrowth. It was like the shot that was heard around the world, and we brought them together, and they cannot be pulled apart anymore. In this study, and I'll talk about it later, the prevalence of abnormal breath tests was 80% in IBS. So such a high prevalence. However, if you look at this criteria with a double peak in subsequent studies in 2005, 6, and 7, there's not much of a difference between IBS and healthy controls. Same thing if you look at this hydrogen rise at 20 parts per million by 90 minutes, that difference kind of goes away between, again, IBS and controls. Same thing at the 180 minutes. Again, Pimentel has an article in 2003 that does show a difference between IBS and controls, but this was unique. According to these two publications that I keep mentioning, because it's such a big deal that there's actually consensus and that at least some organizations have put out what exactly we should be looking for. This has fallen by the wayside. Again, we are not looking at these different criteria to indicate positivity. We're now establishing that these two factors are positive in terms of bacterial overgrowth. So a greater than or equal to 20 part per million rise by 90 minutes. And then this other entity, which it really probably shouldn't be called bacterial overgrowth, but should be called more methane positivity. And what that means is that if you have a greater than 10 part per million at any point of methane in the breath test, then you have intestinal methane infection. So this is I guess a theoretical question for the audience, but should I get a breath test before considering treatment in a patient with IBS? So patients are asking this, providers are asking this, everyone's asking this. And so what the next part I'm going to talk about is really the two sides of whether or not you should get a breath test. I don't claim to know the right answer. I'm just going to present to you the reasons why and the reasons why not. I'm going to first present the adamant no answer. No, you should not get breath testing. And the reason why that people say that is that breath tests suffer from limitations in accuracy. Another issue that people have is that the breath tests don't really guide response to antibiotics. So a lot of people say that breath tests don't guide therapy. So treatment is often empiric. So why even get this extra test? Difficult to obtain. Patient has to prepare. There are a lot of false positives. There are a lot of false negatives. I might as well flip a coin. Then why don't I just give the patient antibiotics? And I'm going to show you this study from Gut in 2011, where 40 subjects who had symptoms consistent with IBS underwent lactulose hydrogen breath testing. And the smart part of this test was that they were simultaneously underwent this lactulose hydrogen breath testing, and then they also underwent nuclear scintigraphy. So they took a nuclear meal that basically traveled with that lactulose. In this study, about 63% had an abnormal lactulose hydrogen breath test at 180 minutes. It was lower when you looked at the 90-minute mark. So it was 14 out of the 40 patients, so 35% with an abnormal breath test. But what they found was that 88% of people who had a positive lactulose hydrogen breath test, so at the time of positivity, when they said there was that 20 part per million rise, there was greater than 5% accumulation in the cecum at the time of positivity. And for many of those patients, it actually was even higher. It wasn't so low, 10%, 20%, even greater than 30% in almost 6 patients. So this has been shown actually also with the glucose breath testing, where they did a similar study in a similar population, showing that there was a collection already of that substrate in the colon. So this side of the story, ultimately what they say is that breath testing is flawed. There's got to be a better test. We can't use breath tests. And so one of the future kind of directions that I was looking at is this ingested capsule technology, where you can actually ingest the capsule and then it opens up in your small intestine, captures a little bit of that bacteria, and then will come out and you can retrieve it and look for bacteria and overgrowth of bacteria. What about yes? How about yes, you should totally do breath testing. You should never give antibiotics prior to doing this. We need to identify bacterial overgrowth. Symptoms are so nonspecific. I just gave you, right, the symptoms for IBS. All of us basically have bacterial overgrowth. The issue is that we need to phenotype the patient so that we can actually figure out, is this going to work or not? We know that IBS is associated with a higher prevalence of bacterial overgrowth, but not everyone should get antibiotics, right? The second reason that these people suggest doing bacterial breath testing is methane production. And I'll show you that literature. Why is methane production so important? And then finally, positive breath testing does predict response to antibiotics. According to Pimentel and his the ACG clinical guideline, they actually suggest doing glucose breath testing or lactulose hydrogen breath testing for the diagnosis of bacterial overgrowth in symptomatic patients with suspected motility disorders. And they gave it a conditional recommendation with very low level of evidence. So now is where I'm going back to this 2000 article that I said there was such high prevalence, nearly 80% of patients who had bacterial overgrowth in IBS patients who presented with these symptoms. They found that after treatment with various types of antibiotics, so in this one they used doxycycline, augmentin, amoxicillin, ciprofloxacin, successful eradication of that bacterial overgrowth significantly reduced bloating, diarrhea, and abdominal pain, such that almost 50% of people didn't even fulfill Rome 1 criteria anymore. They didn't even have IBS. So, and what they found was that there was really no change in those who were successfully eradicated. Many studies do show this. This is actually consistent in the literature. If you have a positive overgrowth test, and then later prove that you eradicate or resolve that positivity, you are more likely to improve in terms of your symptoms. This is also recent literature from the Target 3 study. And just as a reminder, the Target 3 study was looking at Rifaximin in patients with IBS diarrhea. This is a subset of patients who got actually breath test at their baseline. Then again, after completion of a 2-week course of open label Rifaximin, 550 twice daily. And then again, after retreatment with Rifaximin. And what they found here was that 60% of patients who had IBS diarrhea and a positive baseline breath test responded to Rifaximin versus a lower percentage of about 26% of patients with a negative breath test. So that odds ratio was about 4. If you had a positive breath test, you would respond to Rifaximin. The response rate in patients whose breath test normalized was even higher, so at 77% or so. And this is again kind of supporting Pimentel's initial article and many other articles since that time. You can see also clinically those patients did improve for the composite endpoint, which was abdominal pain as well as stool consistency. Something to note though about this study is that the definition of positivity is a little bit in that gray area again. And so it hurts to read some of these studies because some of that gray area, how we diagnose positive bacterial breath test, if you're a purist and you say, no, I want the 20 part per million, a study like this may show that actually the differences in those who were positive and those who were negative, that's no longer clear. But according to the way that they interpreted positivity, this did show that there was an improvement in those who had positive breath tests and who later on tested negative. Back to the second idea of methane. Intestinal methogenic overgrowth is a newer concept that has been coined now by this ACG guideline. But methane and positive methane production is defined as greater than or equal to 10 part per million at any time during the test. And that's also, again, by the ACG as well as the North American consensus that came out in 2017. It's a little bit debatable if this should actually be a rise of 10 parts per million in methane. Methane is actually produced by the key methane producer is this Brevibacter smithii, and it belongs to the domain of archaea, so it's actually not even bacteria. So is it actually overgrowth or not is unclear. About 10 to 20% of the population do create methane on their own by this bacteria, but the whole idea is that perhaps this is leading to some symptoms of overgrowth, meaning there could be constipation, bloating, kind of these other symptoms. And so whether it's in the colon or in the small intestine is unclear. The reason why this matters is that there are a few small studies that do show a correlation between methane production and constipation. So in these two studies, you can see that they looked at the area under the curve for methane on a lactulose breath test. And the higher the area under the curve for methane in these patients with IBS, the more their stool, their Bristol stool was lower, meaning your Bristol stool was more towards 1 to 2 if your methane production was higher. And therefore, this correlates with severity of constipation. At our institution at BI, we actually looked at our data in patients who had constipation, in particular, who have IBS and underwent glucose breath testing. We did not find a correlation with constipation and bloating with those methane levels. But we did find that constipation itself did correlate with baseline levels of greater than 10 part per million and greater than 20 part per million. So the reason why this is important, again, is that in a lot of these studies, when they say methane positivity, they're talking about 5 parts per million. I've seen studies where they say 3 parts per million, then you're a methane producer. But it's actually possible that you could have methane and be suffering from diarrhea or complaints of diarrhea or constipation. And so it's not as specific. So it's important to look for that, again, that cutoff of 10 part per million or even 20 part per million. Treatment for methane production again in small studies, have shown that there is an improvement in patients if you treat that methane production. So in this study in 2014, patients with IBS constipation were given neomycin and placebo versus neomycin and rifaximin. And this is a small study. It's about 31 patients. There are some that were lost to follow-up, but overall, after treatment with neomycin and rifaximin, they found that constipation severity did improve. Finally, I'm going to talk about treatment of bacterial overgrowth. I think that for the most part, everyone turns to antibiotics, but I'm going to talk about diet and other kind of alternatives as well. But clinical trials are limited in regards to bacterial overgrowth treatment. There's a reason why there is not one FDA-approved medication right now, because the studies are small and the quality is poor to even modest at best. And so the guidelines, the ACG guidelines say that in subjects with an abnormal breath test, retesting after treatment may correlate with symptom improvement and may be confirmed by normalization of hydrogen or of that methane. Here I'm just giving you the meta-analysis, one of the meta-analyses that have been done, but the meta-analyses on rifaximin in bacterial overgrowth. So you can see that according to this treatment and improvement in symptoms, rifaximin is safe and it's effective. But in all of these studies, in over 15 of these studies or so, the range is very wide in terms of dosage. So we're ranging rifaximin between 600 milligrams to 600 milligrams, anywhere from 5 to 28 days, so almost to a month in some studies. Symptoms did improve or disappear in more than 2/3 of the patients, but it's interesting to note only one of these studies is placebo, a randomized placebo-controlled trial. There are other antibiotics out there. So clinicians, patients, I think we all think about rifaximin because all of that has been extrapolated from the IBS diarrhea literature and the target 3 and target 1 and 2. But there are other antibiotics out there. Augmentin, for example, is one of the ones that can be used. Flagyl is used. Bactrim has been used. So this is just another kind of slide out there to just say, yes, rifaximin is the treatment of choice because of probably side effect profile and probably because of some of that literature from IBS. But there are many smaller studies that do show that these other antibiotics have the potential to work. What about alternatives? There's really a lot of research going on about alternatives to antibiotics, and I have a lot of patients who come and see me and say, well, I don't want antibiotics, I want something else. I want herbs, I want probiotics, I want a fecal transplant. And currently, there is a lack of consistent data to really support probiotics in the treatment of bacterial overgrowth. And just as an example, there's one study right now looking at brain fog in patients who have bacterial overgrowth. And they found actually that there was a correlation with that probiotic, and stopping the probiotic actually improved that abnormal breath test. In terms of fecal microbiota transplant, it really hasn't been shown in any studies at this point that it actually helps with bacterial overgrowth, even though it's just so exciting to think about getting a stool transplant and resolving everything. What about bacterial overgrowth and diet? It makes sense, right, to reduce fermentable products, so low fiber, avoid sugars, these alcohol sugars, these fermentable sugars. This always astounds people, though, when I'm giving this talk, that there are no great studies looking at the correlation between bacterial overgrowth and low FODMAP. The low FODMAP literature and the reason why we suggest even doing low FODMAP when somebody has bacterial overgrowth is really extrapolated from IBS. One study did show for patients on a low FODMAP diet that there was decreased hydrogen production, but it actually didn't correlate with symptoms, and it wasn't significant in terms of decrease in the hydrogen production. Some recommend a low FODMAP diet following antibiotic treatment for Sibo to kind of starve out any excess bacteria. But unfortunately, right now, we don't have studies that are available to either confirm or deny this. But in practice, I see people doing this, and I understand why. But at this point, we just don't have studies that prove or disprove it. This is just one study that I was looking at, that there's a little hint that the FODMAP may help those who have positive bacterial overgrowth. This is a 90 patient study. It's 90 people who underwent this low FODMAP diet who had IBS for 6 weeks. And they did a smattering of fructose, lactose, as well as small intestinal bacterial overgrowth breath testing. And you can see the prevalence here, that there was 13% of those who have this IBS who had a positive bacterial overgrowth. And this was I believe is a lactulose breath test. So relatively low. But the number who actually have that positive test are 12. And their criteria for positivity was 10 part per million. So again, less than that 20 part per million rise that we like to see now with the consensus. And it's not sure how the people did in terms of whether they were negative, but the people who were positive seem to improve. And so this is just one example. There's always a little bit of hint in these studies that perhaps the low FODMAP can help these patients, but it's just not clear if the positivity resolved, and then what happened to the negative patients. And so in the future, I think there will be studies, but at this point, we're still waiting for them. So in summary, the relationship between bacterial overgrowth and IBS is complex. There is a high prevalence of bacterial overgrowth in IBS. Breath testing has its flaws. We're limited by false positives and false negatives, but the North American consensus and the ACG guidelines do recommend that you get breath testing prior to treatment for bacterial overgrowth. And ultimately, we want to phenotype these patients. We want to phenotype someone before we just blast them with antibiotics, which I think is is a very or a more refined way of treating someone, as opposed to just empirically trying a bunch of things. Antibiotics remain a cornerstone of treatment for bacterial overgrowth and thus IBS. Oh, sorry. And then diet and bacterial overgrowth, I think there's something there. The question is it for prevention of recurrence? Is it about treatment? I think the tests, the studies for this will come, but we have to stay tuned. That's it. So I'm gonna hand this back over to you. Sorry, I'm just gonna stop sharing my desktop.
Okay, so we do have a few questions.
Great.
If someone is taking antibiotics like Xifaxan for 2 weeks and they see no change in symptoms, is it still possible that they have Sibo, and what can they do?
So I'm assuming there was no breath test that was done before the Rifaximin.
It wasn't mentioned, but it just basically there was no response to the Xifaxan. So what would be in regard to symptoms?
So this is the thing. And so this is my opinion, but I'm sure out of 10 gastroenterologists and 10 clinicians, any people, they'll have differing opinions. For my practice, I generally don't really care that much about you during, or that patient during the actual taking of their Rifaximin. I think that IBS and those symptoms are longer term. So there are some people who feel like amazing, but only during the antibiotics, and the moment that those antibiotics stop, they suddenly don't feel good. And my take is always, I like to see the person about 6 weeks after the antibiotics to see what the flora does after treating with antibiotics before we say whether or not you responded to antibiotics. And this kind of speaks to my other kind of issue. The part of me that wants to do a breath test generally for patients before empirically treating with them is that then I have a direction to go with. If a person has a positive breath test, it doesn't mean rifaximin is the only treatment. Potentially they're resistant to rifaximin, I need to use another antibiotic. And so with a positive breath test, I'm more likely to say, I am willing to give another round of antibiotics, a different antibiotic, to see if that changes the flora such that there is no more bacterial overgrowth. And in a perfect world, where money wasn't an issue, where time wasn't an issue, where we didn't have COVID, then you could get a repeat breath test and confirm it was positive before and it became negative now. You should have improved. And if they didn't, then you say that's not the component, that's not the issue here. I don't keep needing to give you antibiotics. I think that's better antibiotic stewardship, but in practice, almost no one ever does that. But yeah, I typically wait for antibiotics. I don't like to look during the time that they're actually taking it. That doesn't necessarily mean anything to me.
Gotcha. So another, this is kind of a little bit more of a comment, but there's a practitioner that works with short bowel syndrome patients and those with pseudo-obstruction. And she said that the low FODMAP diet applied in these patients has been successful. There's limited data, but limiting fermentable carbs makes sense in this patient population. And certainly in my practice, I've seen similar, and I think, another important point in bacterial overgrowth is in some cases, like untreated celiac disease, inflammation in the small intestine might have set the stage for bacterial overgrowth. We get them on an individual, like in that case, on a gluten-free diet and the inflammation resolves and we understand why they developed Sibo probably, and we put them on the gluten-free diet, we treat them, they're good. In those cases. And then many cases with small intestinal bacterial overgrowth, we just don't know the underlying risk factor, or the risk factor is one in which we can't correct. But if we can identify a correctable risk factor, that's the best, because we can say, okay, we've got it, and you probably will benefit from the antibiotics and move on.
Right. And I think that's what's frustrating about IBS, like all of that literature about, what is it about, again, what IBS patients, what is it that predisposes them to get bacterial overgrowth? It's really not clear.
Right.
And that is the frustrating part. Then what does that mean? That yes, perhaps you can get better with antibiotics, but if I'm going by the target data with the rifaximin, those patients may recur, right? There's about a 50% chance that you're going to recur in 6 months or a year. Right. And that, yes, you may respond to treatment, but about half of people will respond. And so you could look at it as like glass half empty, half full kind of thing, where, right. Well, 30%, 50% didn't recur and they felt better. Right. And perhaps that one-time antibiotic dose was good enough. I think, again, extrapolating to bacterial overgrowth, people like that idea, that maybe it helps them, but it's frustrating then for all that those people who do recur, what exactly is it that makes them get those symptoms again?
Exactly.
Is it bacterial overgrowth, or is it IBS, meaning IBS another reason, as opposed to gut dysbiosis and overgrowth of bacteria?
Exactly. And, really understanding the difference between a small intestinal sort of disruption in bacteria versus a colonic disruption, that we really feel like there is known dysbiosis per se in the colon of some IBS patients, and how would we treat that differently? Because right. From what I understand with rifaximin, it works best in the presence of bile And
Mm-hmm.
so it may not work as well in the colon versus the small intestine. So again, if it was more of a colonic, who knows? Just like
Right.
we don't know about diet, there's a
Right.
lot of research to be done, right?
Right, exactly. And so I think, the nice, new step that we're taking with this ACG guideline, with the North American consensus, is they put out recommendations about what should be positive, kind of
Yeah.
standardizing things so that we can be on the same page when we're talking, as opposed to there was a little bit different criteria for admitting these people into the study. Actually, this isn't my patient, right? Like, so
Right.
you don't
Right.
want to take these patients from the studies that they're presenting, because they're not the patients that you have in clinic, or that you actually have. So I think that's, hopefully this is a step in the right direction, and hopefully more research is going to help us with figuring out about diet, about alternatives to antibiotics.
Exactly. So one question, and I know the answer to this, so let's see, I'm going to direct it to you. Any correlation between increased incidence of Sibo in patients who have had their gallbladder removed?
Kate, you were just talking about bile acids and that change to the flora. And so, yeah, there is some literature to suggest that there is some change to them. Yeah, that there is increased risk. But again, the risk, the issue with that is that how do we figure out who are those that have increased bacterial overgrowth because of that? Because even in the diarrhea population, we don't have any tests to suggest bile acid malabsorption and changes to the microbiome because of that bile acid.
Yeah.
It's available in Europe, but we don't have that here. So
Right.
I think that yes, the short answer is it's a risk factor, but it's unclear who gets bacterial overgrowth and who doesn't.
So from my literature search, so we'll get this answer for you, that I read that having your gallbladder removed may predispose you to diarrhea, obviously from the bile acid diarrhea, but that it may lower risk of developing small intestinal bacterial overgrowth. So we will get the
Yeah, we'll
answer
look
for
at
that.
Yeah, I haven't seen that.
Certainly can affect your GI symptoms post having your gallbladder out, as we all know.
Yeah.
But there may be, and I don't know if it's because the bile acid itself can have maybe some antimicrobial, and maybe, I don't know. We'll get to the bottom of that, but I have seen that in a paper. But to your answer, as you can see in the literature with this, PPIs might be a risk factor, then they're not a risk factor. Having a gallbladder out, there is this back and forth, so it may be that it's different in different papers. The next question was, is it necessary to be off a probiotic for 2 weeks prior to breath testing?
Right. So the consensus did not specify, I believe, the exact timing. In our institution, we say at least 2 weeks to stop it.
Okay, great.
Yeah. But some institutions in breath testing, they actually don't stop it. So but again, the consensus did say to stop it.
Okay, so I have a couple questions regarding rifaximin and like how many courses is safe? Is it considered safe for a patient to take 3 courses of rifaximin within a 6-month period? How often can you treat people? Is there a limit to that? Is there a general consensus around how many rounds of rifaximin?
Well, that according to that Target 3 data, right, within 6 months, people got 3 dosages and it was safe.
Okay.
And so with that, that's the reason why, we say that recurrent or prescribing it multiple times is okay. In practice, most of us will give repeat doses of rifaximin, but after my 3rd dosage, like if I prescribe a 3rd dose, I have that internal ticker that says, what are we doing? Is it actually helping, or am I hurting the microbiome?
Right.
And it's not clear, right? We can't have studies that keep going on for years and years and show that you can get 20 courses of antibiotics and still be okay, or, you know, that it be safe. But so many, I have seen patients who come who've been on chronic years of rifaximin once daily or twice daily, and they say that they're doing well on that. That's not you know, a common thing to do,
Right.
but it clearly is that some clinicians will allow chronic therapy,
Yeah.
chronic suppressive therapy, but I think that's rare. And I think most of us are willing to give those 3 courses at least.
Yeah.
And then kind of it's anecdotal in terms of what exactly you want to do.
Yeah. The other, it was more of a comment, but just regarding the breath testing guidelines, you know, that based on the ACG, you know, clinical criteria, and, you know, everything was low level of evidence. And does it, you know, does it feel like these are real guidelines, or are we really kind of guessing still?
Well, I think we're still guessing.
Yeah.
That's the short answer, and maybe not the nuanced answer. I think that it's a consensus statement amongst the people who feel very strongly about bacterial overgrowth. I agree that we need to do more research, we need to set standards, and that's why I think it was important that they put something out.
Yeah.
But you can't deny the literature, meaning, you know, even when you try to do meta-analyses, you do systematic reviews, most of the time you exclude so many studies because there wasn't blinding, there wasn't randomization, there were all of those things that make a study a good study weren't there.
Right.
And that's why they make you're right, all their recommendations are, you know, low level of evidence. And so hopefully, again, now that they've put out what they believe to be positive breath testing, how it should be done, and then some guidelines and recommendations about further studies, at least that we can take that and use it, as opposed to kind of everybody doing whatever they want and then trying to publish and make a correlation.
Yeah, I think that's really important. And just a couple points that I think are important to Dr. Nee's really beautiful presentation, thank you very much, was that, you know, again, there hasn't been really any diet studies looking at what is the best diet for SIBO. Because SIBO symptoms mimic IBS, we do see in clinical practice that reducing fermentable carbohydrates can help manage some of the patient's symptoms. It's not a treatment modality in the sense that it's a treatment to get rid of bacterial overgrowth. The treatment for bacterial overgrowth is antibiotic therapy. And to that point, there's one study looking at herbal therapies out of Johns Hopkins that compared 2 different products, a Methogenic product, a Biotics product. They compared it against 1,600 milligrams of Rifaximin, which is a little bit lower than the dosage that's typically used right now, and found comparable eradication rates in their SIBO cohorts that they studied. But this is one study. This isn't multiple studies. It's been repeated over and over again. So do we have would you say we have strong data to support herbal therapy in SIBO treatment?
No.
We have one study, so I think no, right?
Yeah, and I think it's so attractive. I have had a lot of people come asking about herbal remedies because they said, well, why would you ever give me rifaximin if I can take this herb? But it's unclear from that study, you know, what the natural history of bacterial overgrowth is, what breath testing is like. Their idea of their criteria was also a little bit different. But again, it's just a suggestion that perhaps we could use herbal remedies. That's great. We could use oregano and berberine and all of these, you know, herbal remedies. That would be amazing. But I think it needs to be studied more than this one particular, just because they use so many different products.
Exactly. So I think it's important. These aren't saying that herbals cannot or ever be an option. We just need to see more data. It's
Right.
not to say that if someone says they have a specific diet regimen that's going to cure you of your bacterial overgrowth, I would probably close the door and walk out of the office, because we don't have that literature to support that. Outside of another study looking at an elemental diet, that was the only one study where they looked at like using a Vivanex, a liquid elemental formula, that did show some eradication in the Sibo. I'm not sure what the follow-up was to that. So again, you may see some, alternative practitioners or some practitioners really pushing certain therapies. And I would just caution you to be careful as a practitioner to really stick with evidence-based medicine and really follow this. We want to help patients. We want everyone to feel better, but we also want to be very, following the science and doing this in an appropriate way.
I always have. I totally agree with you. When I get second opinions about bacterial overgrowth in particular, I always have the mindset of I don't want to do harm. And there can be harm that I do by saying, yeah, go do the herbal remedy that you want to do, right? I usually, it's an educational opportunity going through basically this talk. It's basically understanding what are the issues with what we've said is bacterial overgrowth, but then also giving the opportunity that what are the risks and benefits of said treatment. And I think that's the marker of a good relationship when you have that with your gastroenterologist, your nutritionist, whoever, but just to talk about that back and forth to say, what is the risk, what is the benefit, and what am I exactly treating, what does the evidence show, so that it's not just shooting in the dark and just giving you anything.
Exactly. And I know we're running over, but do you have a second for just like one more quick question? And then I'll try to get to some of these other ones in a follow-up email. Just the question of the role of a prokinetic in the treatment in bacterial overgrowth. I know Dr. Pimentel has always kind of encouraged that in his, in his dialogue and in lectures and information. So what are your thoughts about that?
This is more of a personal question, or
No, I think, a lot of practitioners that may be online, are answering these questions, helping their patients, working closely with different practitioners. And I know not everyone's on board with prokinetics. So as a practitioner, we have to kind of also field those questions, right? That a patient.
So usually, so I have seen it done, and I myself, I admit I have used it as well, a prokinetic after treatment of the bacterial overgrowth with whatever antibiotic. And this is, I typically would use it in somebody who has had multiple treatments already for bacterial overgrowth.
Mm-hmm.
In terms of when I use it and when I don't, that's not clear. So I don't have a great answer to that. I think one of the things that gives me pause about giving a chaser or a prokinetic chaser is that a lot of what I've said about this breath testing, if it's a surrogate for oral cecal transit time and that your transit is actually fast, using a chaser or a prokinetic is actually opposite to what I want, right? And that we're looking at a false positive. And that's just something that I keep in the back of my mind. But I will try, if somebody has improved with antibiotics previously, but then recurred after a period of time of wellness. So if they've had a few months of being well, if it then recurs again, I will sometimes use a chaser.
Yeah. And I wonder about like Procalipride, it has some of that prokinetic effect. And if in certain patients, if that might be an option if they're presenting with constipation, right?
Yeah, I mean, so Procalipride's so exciting because it's a prokinetic. It's now FDA approved for constipation. I use it off label sometimes for patients with gastroparesis. So there's no reason why it wouldn't help potentially in the small intestine as well, even though it's been shown more in the colon and then potentially the stomach. But I agree, it could potentially help as a prokinetic that maybe has lower risk compared to the other ones that we kind of use for that purpose.
And then just one last quick one. The anti-CBD and anti-vinculin testing and IBS Smart, and
Yeah.
use those?
I don't use them as much. I have had patients who ask me to get it for them or test it, and I do. Usually, right now, I don't change management based on that test. And so I think it's very helpful for us in terms of using that potentially for studies to look at post-infectious IBS patients.
Yeah.
But right now, I typically don't get it because of the cost, because of the lack of change in management. So I typically don't get that.
Okay. All right. So we do have a few more questions, but I don't want to really take Dr. Nee's time. She's been very generous. We'll try to get to a few of these, post. We maybe answer some of them in the email. But thank you, Dr. Nee, for your time today. We really appreciate it.
Great, thank you.
And thanks to everyone for listening.